Hi, I'm Megan Bronson. I am the CaTS Research Navigator based at Tulane University. It's lovely to see so many names and faces joining us for our inaugural session today. Thanks so much for being here. Just to remind everyone, we're proud of Louisiana's scientific response to the COVID-19 pandemic. And the CaTS Center started the Louisiana COVID-19 Chronicles series back in October 2020 as a result. As an extension of that series, we welcome you to this, our inaugural session of the CaTS Lunchtime Lagniappe Seminar Series. It's a monthly seminar. As a resource to all scientists, clinicians, and citizens, we invite you to learn more about what our researchers are accomplishing throughout the state in their work related or not related to COVID-19. Topics and speakers for each seminar are announced via the CaTS email list, calendar of events page, and Twitter as they are finalized. We hope you will join us for future sessions of the CaTS Center's Lunchtime Lagniappe Seminar Series. Just a little bit of housekeeping. During the talks, be sure to mute yourselves. We'd like to keep questions to the end. So with that, please type your questions in the chat window, or once Dr. Myers has concluded, you can unmute yourselves and ask a question at that point. So Dr. Myers, thank you for joining us today. Can I give a little introduction about you?
Please.
So Dr. Candice Myers is an assistant professor and director of the Social Determinants and Health Disparities Laboratory at Pennington Biomedical Research Center. Her research largely focuses on food insecurity as a key social determinant of health and source of health disparities, with a specific focus on its complex relationship with obesity and cardiovascular health. Dr. Myers also studies the impact of place on health disparities and intervention response using multi-level theories and methodologies. She also has extensive research expertise in spatially modeling geographic disparities in obesity and diabetes prevalence across the United States. Today, she will discuss food insecurity and associated health disparities in adiposity and weight loss. Dr. Myers, take it away.
Great. Thank you for the introduction, Megan. And I'd also like to add, well, first I'd like to say thank you for the invitation to share some of my research with the CaTS Professional Development Corps and all others who are attending today. But I'd also like to mention the CaTS Roadmap Scholar Program, of which I was a part of the 6th cohort from 2017 to 2019. Want to give a shout out to that program because it has been instrumental in allowing me to make the transition to research faculty and pursue kind of my passion in research around food insecurity and its relationship with health disparities. So with that, I'll get started. So today I want to talk about food insecurity and adiposity among US adults using some data from NHANES. I also want to focus on a secondary analysis from a recent weight loss intervention that was conducted in primary care settings in Louisiana. Specifically, I want to focus on the moderating effect of food insecurity on weight loss among those patients in that randomized clinical trial. And then quickly, I want to finally touch on moving forward with food insecurity research. The American Heart Association recently released a policy statement regarding food security or food insecurity in the US, and specifically moving toward the concept of nutrition security. So to get started, I first want to define food security versus food insecurity. Food security is access by all people at all times to enough food for an active and healthy lifestyle. Conversely, and more negatively, food insecurity exists whenever the availability of nutritionally adequate and safe foods, or the ability to acquire acceptable foods in socially acceptable ways, is limited or uncertain. So I want to focus here on food insecurity as the more kind of negative or deleterious health, social determinant of health. Importantly, food insecurity is an issue of food quantity, that is not having enough to eat or actually having disrupted non-normal eating patterns. It's also an issue of food quality, and that again relates to the idea of having nutritionally adequate and safe foods at all times. And so very often, because of this, food insecurity can have a negative impact on both nutrition and diet because it is compromising diet quality for those individuals who experience food insecurity. Importantly, food insecurity is linked very often to compromised financial and material resources. So we can think of things like income, employment, finances, their ability to actually have enough money to purchase food on a consistent and regular basis, but also to purchase healthy foods on a consistent and regular basis. And so because of all these things, food insecurity is a key social determinant of health, and very often it underlines a number of key health disparities that I would like to talk about today. But first, let's also talk about how we measure these two concepts here in the United States. The United States Department of Agriculture measures food security or food insecurity based upon a series of questions about conditions and behaviors that characterize difficulty meeting basic food needs. And so the USDA has developed the Core Food Security module, and this module has 18 items. These 18 items or 18 questions you can see here in the diagram provided. These are issues related to worrying about food running out, buying food or food that was bought did not last, not being able to afford a balanced meal, or even cutting the size of a meal or skipping meal. So again, issues related to the quantity of food as well as quality of food. And so among those 18 items, 3 reference the household, 7 reference adults, and 8 reference children if present. So we have a series of questions here that really capture household food insecurity by focusing both on adults and if present children within the household. Importantly, the questions typically reference a previous 12 months. They can be modified to reference a previous 30 days or 1 month. And in order to determine one's food insecurity status, if there are 3 or more affirmative questions to those 18 items, typically that household or individuals within that household are characterized as being food insecure. So that's how we measure food insecurity here in the US. Food insecurity is a very prevalent issue faced by many US households, families, and incomes or individuals. We can see here that in 2018, overall, the food insecurity rate in the United States across all counties and parishes was 11.5%. And we can obviously see, looking at this map here of county and parish level food insecurity rates, there are certain geographic places within the United States that have higher prevalences of food insecurity. So obviously we're talking about an issue that's prevalent across the United States, but is specifically an issue in certain parts of the US. And of course, I would like to point out that food insecurity is very prevalent among counties, parishes, and states in the Deep South, ranging from Arkansas, Louisiana, Mississippi, Alabama, and Georgia specifically. So this is a very relevant health issue for researchers who are concerned about the health of populations here in our southern region. If we focus on Louisiana specifically, we can see that the food insecurity rate across parishes in Louisiana is 16.1% in 2018. Again, this is significantly higher than what we see kind of at the national level. So this food insecurity really is a very prevalent issue here in Louisiana that has obviously consequences for our population when we think about health behaviors and health outcomes. Importantly, or at least where most of my research focuses on, is the link between food insecurity and obesity. And at face value, this is very often considered to be a paradox, because when we think about food insecurity and the idea of not having enough to eat, we would think that this is maybe associated with lean body weight, or even kind of under normal body weight or underweight. Oops, sorry. My fault, excuse me there. But importantly, what the data do show is that food insecurity is linked to greater body weight, especially obesity. So if we look here at this rubric that was created, this diagram that was created by Seligman and Schillinger, we can see that food insecurity as a social determinant of health is directly linked to constrained dietary options. And the data do show that food insecurity is associated with lower diet quality compared to food secure adults in the US. Food insecure adults report a 2.22 unit lower healthy eating index score. So what it's telling us is that there is a direct impact of food insecurity on diet quality, and that is a negative impact. So that's very important. It's established in the literature. What this leads to then is an overall positive association between food insecurity and body weight. So obesity, hypertension, diabetes, these are the negative health outcomes that are associated with food insecurity. And again, a recent meta-analysis actually showed that the odds of high body weight are around 21% higher for food insecure than food secure participants among all those studies that have actually looked at food insecurity and its association with body weight. Further, if we follow the path in the diagram here, we can see that being food insecure is associated with substantially greater subsequent health care expenditures. And obviously this makes sense, as food insecurity is related to negative health outcomes. And then we actually have to spend more money to address those negative health outcomes in individuals who experience food insecurity. The data show that food insecurity compared to being food secure is associated with 25% greater total healthcare expenditures among US adults. And so this increased healthcare expenditures obviously lead to further competing demands when it comes to those individuals who are experiencing food insecurity. So with that relationship established quite well in the extant literature, we recently undertook an analysis of NHANES data because we really wanted to better understand the extent of the relationship between food insecurity and adiposity among US adults. And so in order to do this, we focused on just those individuals 20 years of age and older in the US, and we wanted to look at national trends in food insecurity by adiposity. And so we were able to utilize data from the NHANES, which is the National Health and Nutrition Examination Survey from 1999 to 2016. I'll add a caveat here that there have been more recent data released that include food insecurity measures from NHANES. And moving forward, we will incorporate those data into our new analyses. But for right now, what we have are data up until 2016. Importantly, NHANES does use the 18-item US Household Food Security Survey module that I mentioned earlier. That's been developed by the USDA and is kind of the gold standard for measuring food security, food insecurity here in the US. For adiposity, we essentially used BMI as kind of our adiposity proxy. And of course, we focused on the three categories of BMI: normal weight, overweight, and obese, according to kilograms per meter squared. So those three categories of BMI are kind of our measure or proxy of adiposity. And so what do we have here? These are crude weighted trends in food insecurity. In food insecurity among US adults from 1999 to 2016. NHANES is conducted in 2-year cycles, so we can see that our 2-year cycles are kind of grouped together. If we look overall at food insecurity prevalence among US adults in 1999 to 2000, we can see that the prevalence of food insecurity was 8.7% among all US adults. Importantly, if we look at the data most recently from 2015 and 2016, we can see that food insecurity prevalence increased significantly to 18.2%. So that's a quite striking increase in food insecurity prevalence among all US adults. But again, what we were really interested in was looking at how this breaks down according to adiposity. And what we have here are kind of our BMI categories so that you can also see the prevalence of normal weight, the prevalence of overweight, and the prevalence of obese across the same time period as we're looking at food insecurity prevalence. And again, what we see is that in kind of all of these categories, we see general increases in food insecurity prevalence among US adults. But importantly, what we really like to point out are those differences in food insecurity prevalence by BMI category. In 2015 and 2016, we can see that for those adults who have a BMI in the normal weight or overweight category, food insecurity prevalence is at about 15%. However, for adults with a BMI in the obese category, we see that food insecurity is much higher at almost 23%. So here we can see that food insecurity prevalence is greater in those individuals who have a BMI that falls in the obese category. Importantly, we wanted to further look at sex differences in food insecurity and adiposity among US adults. And obviously with the NHANES and the sample size that it affords, we're able to do this. And so we looked at food insecurity among men here in our A diagram, and we also looked at food insecurity among women here in our B diagram. We looked at food insecurity prevalence from 1999 to 2016. And importantly, we broke that down by BMI category again of normal weight, overweight, and obese according to kilograms per meter squared. If we look at men first in diagram A, we can kind of see this general uptick in food insecurity prevalence across all three of our BMI categories, but there's no distinct pattern between food insecurity prevalence and BMI category. However, if we look at our B diagram for food insecurity among women, not only do we see that food insecurity prevalence increased across all years and in all BMI categories, we can really see a pattern start to emerge by BMI category. And what we'd like to point out is that for those gray dots that are connected from 1999 to 2016, those are, that's the BMI category of obese. And we can see that the increase in food insecurity prevalence is much greater in this category of adults. But this is for women only and not for men. So what we're starting to see here is when we consider this relationship between food insecurity and obesity across this time frame in US adults, there's really a striking pattern that emerges among women, specifically those women with a BMI in the obese category, and we don't see a similar pattern for men. So that's something we've been keeping in mind as we continue this research, and it largely fits with what other research has shown as well in this area. So what we also did was looked at the adjusted odds of being food insecure among adults in the US, again, according to, or the differences between men and women. And if we look at those odds ratios of being food insecure by BMI category, what we see that is among men, there are no significant differences between BMI category. The odds of food insecurity was not related to one's BMI category. However, if we look at food insecurity odds ratios or the odds of being food insecure among adult women in the US, what we see is that there is significant differences here. Specifically for those women who have a BMI in the obese category, they have significantly greater odds of also being food insecure compared to individuals who had normal weight. We don't see that so much in the BMI category of overweight, but definitely for obese women. So again, we're starting to see a pattern emerge of a sex disparity when we think about food insecurity and its relationship to adiposity among adults in the US. So what we found is that food insecurity prevalence increased in the US from 1999 to 2016 across all levels of adiposity. But what we did find is that food insecurity prevalence was greater in adults with greater adiposity, those adults who had a BMI in the obese category. We also found disparities in food insecurity by adiposity between men and women. Specifically, women with greater adiposity were more likely to be food insecure compared to those with lower adiposity. So this is really a key takeaway from this secondary analysis. Moving forward, we also wanted to understand the relationship not only between food insecurity and body weight, but food insecurity and weight loss. And the PROPEL trial, which was the Promoting Successful Weight Loss in Primary Care in Louisiana trial, really gave us the opportunity to utilize data from this trial in a secondary analysis to better understand the relationship between food insecurity and not only body weight, but food insecurity and weight loss. And so the PROPEL trial tested the effectiveness of a pragmatic, high-intensity, lifestyle-based obesity treatment program in a very large sample of underserved adults with obesity over 24 months. And so the sample was 803 patients delivered in 803 patients situated within 18 primary care clinics across both urban and rural Louisiana. And again, this was over the course of 2 years or 24 months. Importantly, the intervention in PROPEL that was targeting obesity treatment or weight loss was both health literacy and culturally appropriate. And so this was the intensive lifestyle intervention component. Importantly, there was also a second arm to this RCT, and this was the usual care arm. And primary care clinics who were randomized to the usual care arm, those patients just received usual care from their primary care physician over the course of the 24 months, where those patients who were in clinics randomized to the intensive lifestyle intervention received the health literacy and culturally appropriate obesity treatment program within the context of their primary care clinic over the 2-year period. And this afforded us the ability to look at adiposity or BMI at baseline, which was quite interesting. But then also using follow-up data or data across the 2 years, we could look at weight loss or how body weight changed across the 2 years. Importantly, in Propel, we utilized a modified 6-item version of the USDA measure. This 6-item version obviously reduces participant burden and also has health literacy implications built into it. So it's a bit more easier for people to understand and actually respond to, but still comparable to the 18-item USDA module. So at baseline, what did we find? We found that 31% of patients in the Propel trial were food insecure, which is quite a large proportion of patients actually reporting being food insecure. More so than what we kind of see if we remember those data I presented at the beginning, looking at the US or even Louisiana in general. We have quite a large portion of patients that were actually experiencing food insecurity. What we also found was that food insecurity was both significantly and positively associated with BMI. That is, those individuals or Propel patients who reported being food insecure at baseline also reported greater BMI. They were more likely to be overweight or obese. Again, we really wanted to focus on differences between males and females based upon kind of what we've seen at the national level and what we see in the extant literature. And what we found here is that women who were food insecure had greater BMI than their food secure counterparts. And so what we have in our diagram here is BMI according to male and female participants, further broken down by food security status. So those in the dark gray are represented as being food insecure, and those in white are food secure. If we look at males, there's no significant difference in BMI at baseline between food insecure and food secure participants. However, if we look at our female patients in Propel, we can see that those food insecure patients had a greater BMI, a significantly greater BMI than their food secure counterparts. So this was quite striking to see this at baseline in the Propel trial. Importantly, we wanted to understand what that weight loss looked like across 2 years and if food insecurity moderated weight loss in the Propel patients. And so what we have here again are baseline characteristics of Propel patients, but importantly, we've categorized patients according to their food security status. So either food secure or food insecure. And then we further broke participants into the arm, the trial arm that they were randomized into, or that their clinic was randomized into. So here we have usual care and intensive lifestyle intervention groups. So we have 4 groups of patients that we were able to look at in the Propel trial. So we have our food secure patients who received usual care or the intensive lifestyle intervention. And then we had our food insecure patients who received either usual care or the intensive lifestyle intervention. We have a number of body weight characteristics broken down here, as well as a number of other socio-demographic characteristics that we considered. But what we'd really like to focus on is the finding that food insecurity did moderate patient responses to the Propel trial. And so what we have here is body weight in kilograms of all Propel patients over the 2-year trial at baseline, 6 months, 12 months, 18 months, and 24 months. And again, according to those 4 groups that I just specified by food security status, as well as the intervention arm or study arm that their clinic was randomized to. So we have food insecure patients in the usual care group, food insecure patients in the intensive lifestyle group, food secure patients in usual care, and then food secure patients in the intensive lifestyle group. And the point we'd like to really make here is that if we look at food secure patients in the intensive lifestyle intervention, so patients, those data in turquoise represented by circles and a dashed line, we can see significant weight loss from baseline to 6 months, and then also and then further in 12, 18, and 24 months, especially when we compare that weight loss to the food secure participants in the usual care arm, those represented by turquoise circles and a solid line, where we can see there was very little weight loss or weight change in that group. We can see quite significant weight loss and weight change in the other group. Importantly, if we compare our food secure and food insecure participants in the intensive lifestyle intervention, this is where the story really emerges. What we found is that relative to food secure patients, food insecure patients who received the intensive lifestyle intervention versus usual care had smaller reductions in body weight over 24 months. So the mean absolute weight difference between our two study arms was actually 2.5 kilograms lower among food insecure patients than food secure patients. And so while it's promising that our food insecure patients did lose weight in response to the intensive lifestyle intervention, their weight loss was less than that of food secure patients. And so while these are important data and they're showing that food insecurity did significantly moderate weight loss and that it actually kind of blunted weight loss for those patients in the intensive lifestyle intervention who were food insecure, it probably lends more questions than answers for us. But we're going to move forward with these data analysis from Propelled. We have another series of questions we'd really like to answer, but this is at least what the data show us at this kind of first blush. So food insecurity significantly moderated patient responses to the Propel intervention. Relative to food secure patients, food insecure patients who received the intensive lifestyle intervention had smaller reductions in body weight over 24 months. So while those food insecure patients did experience weight loss, it's concerning that their weight loss was less than that of food secure patients. And so, like I said, again, we're moving forward with a number of other analyses to better understand not only the mechanisms that link food insecurity and body weight, but what are the mechanisms that potentially inhibit or even allow food insecure patients to actually lose weight, and what can we do to better address kind of inhibited weight loss in food insecure patients within the context of weight loss trials. And so to quickly wrap up, I would like to point out the new AHA policy statement that was released recently, strengthening U.S. food policies and programs to promote equity in nutrition security. This was a policy statement from the American Heart Association. We can see here that the idea that they're proposing is moving from just food sufficiency or even food security, but really moving towards achieving nutrition security in the US. That is moving from health disparities and really considering nutrition security as an avenue to achieve health equity, knowing that along this way we can address issues of hunger, dietary quality, but also disease management and disease prevention. And so within their statement, the authors state there is growing consensus that U.S. food policies and programs should transition away from the current somewhat narrow term food security and toward the broader term nutrition security that includes having equitable and stable availability, access, affordability, and utilization of foods and beverages that promote well-being as well as treat diseases. And so for me, as someone who focuses on food insecurity, I definitely take this policy statement to heart. I think it's a really good idea that the AHA has put together in moving toward this idea of new nutrition security, especially when we think about health disparities and our need to address them. And so with that, I'll stop today and give acknowledgments to all of my mentors and collaborators here at Pennington, as well as the Propel Research Group specifically for allowing me to utilize the Propel data. And then also giving recognition to some other groups that we've collaborated here with Pennington that have been very instrumental in putting together our research projects. And with that, I thank you for your time and attention today. And if you have any questions that you're not able to get through today, please do feel free to contact me at any time at my email address. And thank you.
Wonderful. Thank you so much, Dr. Myers. We greatly appreciate your talk. It's always enlightening to me to learn where you are with your research and whatnot, and where Louisiana is and where the country is. So thank you for all of that. Be sure and check the chat. Dr. Kerwin has a very kind comment. Okay. And if anyone has, a brief question, we are over time, but if someone has a burning question, we I'm sure welcome it. So looks like there's a quick question that's come through. Have you looked at the relationship between change in food insecurity and change in weight category, weight status, or even BMI? I'm unfamiliar with the terminology. I'm not sure if that's a typo or the right thing. What are some ways, second question, what are some ways, interventions to reduce food insecurity, especially in women with obesity? Dr. Myers, do you want to try and tackle one or both of those?
Definitely tackle the first one. So we currently have a study underway that is looking at food insecurity as a stressor over the long term. So it's an observational study where we're actually going to monitor food security status across 22 weeks and understand how food security status potentially changes over time. And then as a source of stress, how does weight concurrently change with food security status as well? So I think that specific study, which is currently recruiting participants, is going to answer that question, because we do want to understand how the body weight accretion occurs in those individuals who are experiencing food insecurity over the long term. And then our goal with that is what are some, in addressing what are some ways or interventions to reduce food insecurity. I think one of the things that I'm leaning towards is actually trying to develop interventions that not only target weight loss, but target weight loss in the context of food insecurity. So there's some data out there that show when you address food insecurity in conjunction with health improvement or weight loss, you can engender positive health change or reduce body weight. And so it's really about kind of addressing both those conditions of food insecurity as also those conditions of obesity. They're kind of concurrent health issues. And in order to really address the issue of obesity, especially in vulnerable populations, you also have to consider the other issues they're potentially facing, and food insecurity is one of those issues.
All right. Well, thank you. Thank you so much for joining us. Thank you for staying over time. We appreciate it. It looks like additional questions have come in. Unfortunately, Dr. May, I'll go ahead and share this comment, but we are over time, and I hate to abuse people's time and ability and stuff. But Candice, if you see it and would like to follow up with Dr. May afterwards, that would be wonderful. Greatly appreciate it.
I'll take note of that. Thank you.
Excellent. Thanks. So thank you, Dr. Myers, for your time. We appreciate it. Recording of today's session will be available in the next 1 to 2 days. It will be shared via the CaTS listserv and posted to the CaTS YouTube channel. Our next CaTS Lunchtime Seminar Series will be held on Thursday, June 16th, also at 12:30 p.m. Remember, this is a monthly seminar series, and we will announce that speaker soon. We welcome more speakers for the seminar series. If you or someone you know would like to share their work, COVID or not COVID related, we welcome all speakers. So please feel free to email myself or Casey Lindsley at Pennington to get on our list of speakers. So again, Candice, we can't thank you enough for being our first speaker for this series. It's been almost exactly a year since you were supposed to present for the COVID seminar series. So thank you for making it happen today. We appreciate it. Take care.
Thank you for having me.
You're very welcome. Good night. Bye, everyone.
Bye.